That was the nicest introduction I think I've received. Can you all hear me? Should I raise it up a little bit more? Okay. Great. Well, it's really a privilege to be here, so thank you so much. It's always nice to come to New York, too. I don't get down here that often. It's a wonderful city. And I don't have a catchy title, sorry. I need to have like texting and, I don't know, something a little bit more interesting. This is very descriptive, so at least you know what you're going to get this morning. So I'm going to talk about technology for measurement and intervention. I am going to cover two worlds, ART for treatment and then PrEP for prevention. And they are quite different, even though the tools overlap quite a bit. And I'll try to be clear of when I'm talking about each one. So as an outline, I'm going to start off with some basics about adherence. I assume most of you in the room have thought about it, but I know many of you are coming from different backgrounds, so we'll just cover a little bit to make sure we're on the same page. And then I'll talk about the technologies that I've been working with that are becoming pretty common within the adherence world. And then I'll dive into ART adherence. I'll talk about how I've been using one of the devices to really understand this relationship between viral suppression and adherence, and then talk about ways to use devices for monitoring and intervention. And then switching into PrEP, I've done a lot of work within the Partners PrEP study and the follow-up demonstration project, so I'll go over those and talk about how we've been using technology to support PrEP. And then a little bit about ethics related to all of this technology, and just a few concluding remarks. Okay, so adherence basics. Again, sorry if all of you know this, but I just want to make sure we're on the same page. So ART adherence, so when you're talking about treatment, it's very important for viral suppression, and that's very important for clinical outcomes. And having high adherence is really important both for the individual and also for secondary prevention as we think about that aspect of treatment. So adherence has kind of followed a pendulum. Robert and Claude and I and many others have recently been involved in some meetings where we're trying to think about what is the future of adherence and where should we be going with it. And sometimes we're actually met with some resistance, and people say, well, adherence isn't a problem anymore. People are taking their drugs, right? It's really not worth a huge investment or a lot of research. But there's really been a pendulum. So I'm just going to go through a long history in one slide to talk about why I think this is still highly relevant. So back in the 90s, there was a lot of concern about using treatment in people who, quote unquote, couldn't do it. So homeless people, people using drugs. Similarly, in the early 2000s, when ART was being made available in sub-Saharan Africa, there were people, including very high-up administrators in USAID, who thought that Africans couldn't do this. It's too hard. They don't understand what time is. And so the pendulum was swung to adherence is a huge problem. It's such a huge problem, we shouldn't treat people. And then it kind of swung the other way, and which is true. There's a really great review paper by Ed Mills and others showing that people in developing settings have done so much better with treatment. David Bangsberg, who's my mentor, did a lot of work with the homeless population in San Francisco and showed that they can do it as well, if not better, than other people. It's really an issue of focusing on what the specific barriers are and supporting people appropriately. And motivations for treatment and so forth are different in different settings. And especially in developing countries, people have done quite well. So that brings us to the point of, well, maybe we don't need to study this anymore. People are doing fine. But there was a recent review that came out, which I think that date's wrong, but showing that as many as a third of people who are on treatment are failing, even in these areas where people are outdoing our expectations. So I think we're kind of back to the middle, where it was a huge problem, it's not a problem, we're kind of through the honeymoon phase and we're dealing with long-term treatment. So we really do need to pay attention for lifelong care. Now switching to PrEP, PrEP is also an area where adherence has been a huge topic. I think most of you have probably heard of the clinical trials. There have been many looking at the efficacy of PrEP. So these are the large RCTs. Partners PrEP is the one I was involved with. TDF2, Bangkok is a study with IDU population. IPREX was in the States with an MSM population. The Partners PrEP and TDF2 were in heterosexual couples, couples in PrEP and individuals in TDF2. And then young women in FemPrEP and Voice. And during the long story short is efficacy is being shown here on the x-axis and adherence is on the y-axis. There's essentially an exact relationship showing that if you take this drug, it works. If you don't take this drug, it doesn't work. $100 million to show that, but and this is really pretty obvious when you think about it. But as an adherence researcher, this was actually really good for me because it really garnered interest in this area, and to show how important it is to really understand what's going on. Because if you just looked at FemPrep and voice, we wouldn't have this amazing biomedical prevention tool that we've shown in other studies really can be very effective. So it's an important relationship, but adherence is really, really hard. Right? It's messy. It's hard to measure. We don't really understand it. And then we don't know when to intervene because we don't understand that. And our interventions have really been suboptimally implemented and studied because of the challenges of people. It's behavior is messy. So I'm going to talk about technology as a way to hopefully handle some of that messiness. So the two types of technology that I'm going to go through, there are certainly others out there, but these are the types of technology that I work with. Cell phones. I think everybody knows what a cell phone is, right? So texting, interactive voice response, which is an automated way of getting voice recordings, kind of like a phone tree. That can be used to measure adherence with enhanced self-report, getting a little bit of information about what someone's doing in the moment. It could be used as an intervention for reminders, notifications to social supporters. I'll talk a lot about that. Pros of using cell phones. Everybody has one, right? Everybody has two, multiple cell phones, especially in Africa. Many people get out their portfolio phones at meetings. And so you can get data really often. You can get it pretty much whenever and wherever you want. It's relatively anonymous, which may help with social desirability biases and other barriers to good self-report. But not everybody has their own phone. So especially when you're dealing with HIV or other potentially stigmatized conditions, that can be an issue. Reception is not always 100%. People need electricity. People may not understand how to use phones for science. Using phones to figure out when you're going to meet your friends tonight is very different than answering a structured questionnaire. So there are some issues there. And then, of course, missing data. If you're expecting daily text messages for a month and you only get 2/3 of them, how do you deal with that? So very brief overview of some of the pros and cons to cell phones, and I'll get into the weeds as we go. So that me? I know, it happens, right?
Don't say anything bad about it.
No. I do some lectures at MIT sometimes too, and invariably, like, something goes wrong. It's like you're in the house of technology. Anyway, so monitors, there are a couple different types. I'm only going to talk about two, but they're sort of representative of the class of monitors. MEMS caps, you can see up here. These are pill containers that have an electronic cap, and every time you press and release a plunger within the cap, it creates a date and time stamp of that opening as a proxy for ingestion. Not 100% accurate, and then sometimes people take out multiple pills at one opening, or they may open it and just look to see what's in there. Maybe the kids are playing with them, who knows. It's not 100% accurate, but it's a really good way to get day-to-day patterns of what adherence is like most of the time. So I found it to be a very good measurement. And then there's a real-time version of this, and I actually brought one. Talks are always better with show and tell, right? So this is basically a MEMS cap with a SIM card in it. So inside there's a little circuit board and a battery and a SIM card. And so every time you open it, and there's a pill container inside that you can take out and replace, that date and time stamp is now being transmitted in real time. So you can find out about adherence anytime, anywhere. And I'll pass this around in case you're interested. So pros, as I mentioned, you can get day-to-day adherence behavior, which you really can't get any other way. And then you could potentially pair that day-to-day pattern with interventions, and I'll talk about some of my data in that area. They are expensive, but I think the costs are coming down quite a bit. Battery life is an issue, especially if you're working in places where people don't have electricity. And then people may just not want to use it because of stigma. It may not be convenient for travel, that sort of thing. So there are pros and cons. Here's one of our participants who gave us permission to use her photo. This is her home in the background. This is in southwestern Uganda. So you can see she's in an area with no electricity, very few modern implements of modern technology in any way, even including pens and things like that. But she's using our device and doing quite well with it. And this is a recording of the real-time monitoring data that we're getting back, just to give you an idea of what it looks like. There's dates here on the bottom and then time on the y-axis. And each one of these dots indicates an opening. And I downloaded this yesterday on the train down from Boston, and you can see that there was a dose taken on the 14th. So it's pretty exciting that you can get that information 10,000 miles away. All right, so that's the intro, and I'm going to dive into some of the data that we've been collecting on using technology for adherence measurement with treatment. So the first study I'm going to tell you about is looking at that relationship between adherence and viral rebound. So as I said at the beginning, we know this is there, right? We know you need to take your medication to suppress the virus. But how much forgiveness is there? Like how quickly do you lose viral suppression when you stop taking medication? That's really important when you think about interventions and when you think about long-term treatment, especially if we are seeing a third of people fail with more than 2 years of therapy. When do we need to make those interventions? How can we keep people on low-cost regimens, and even here in the States to keep them on regimens that are simpler and easier to access? So David Bangsberg, again is my mentor, had a cohort in rural Uganda. It just finished in July, but had been going for about 10 years. And 4 years into the study, we started enrolling people and using this wise pill device that's going around so that we could understand in an observational way what is their adherence. And then this is not an intervention, although I'll come back to that in a moment. So every 4 months we would see them. We'd do some questionnaires, we'd get their blood for viral load, but we would be getting their adherence data in real time. And when we saw 48-hour lapses, so 2 days or more without an opening, we would go out to investigate. And we looked every Monday to kind of see what was out there. We couldn't do this every single day. There's a limitation, and dealing with real-time data itself is problematic, because you're just overloaded with information. But we decided once a week was a reasonable way to do this, and that would give us some variability in the length of the lapses that we were investigating. And so we would go out, try and figure out what happened. Was this a technical problem? This was 4 years ago, so we were still learning how to use the devices and optimizing them, developing them with the manufacturer. And so when we found somebody who didn't have a technical problem, we drew some blood to see what happened to their virus. So what is the real-time relationship, the in vivo understanding of adherence and viral suppression? And then we did some models to try and figure out what was influencing it. So long story short, what we found were just over 5,000 lapses. So these lapses are happening very commonly, but only about, and the average that we investigated was about 2.8 days. Only about 600 of them were actual interruptions that we could investigate. We knew they had suppressed virus to begin with, got their blood during the interruption, and then could follow up afterwards to see if they were still suppressed or not. And so I won't go through all the different causes of the lapses, but about 18% had technical problems. About half of them already stopped before we got out to investigate. A certain number we couldn't find people, or they didn't want their blood drawn, that sort of thing. But our sample here is about 600 interruptions in a population in real time to see what happens with their virus and adherence interruption. So there were only 13. So this is really trying to find a few needles in a haystack. But what we were able to show is that with each day of the duration of the interruption, there was about a 25% increase in the risk of losing viral suppression. And you can see this graphically here, that as the duration increases, the risk of having detectable RNA increases. We also looked at some other factors like prior duration of viral suppression, the 30 days before the lapse, what was their adherence pattern during that time, their initial viral load, and also the type of therapy they were on because of half-life influences. And we did see that higher adherence is protective. That's what you would anticipate. And then because our sample size was so small, we could only really do univariable analyses. But we saw trends towards an influence of prior duration of viral suppression, as well as a longer half-life medication, both being protective. And we did do some bivariate, there are multiple multivariable analyses with just 2 variables to show that this finding was still robust, even though our sample size was quite small. And then importantly, 83% of these people did resuppress at their next visit. So even though this was an observational study, it really was interventional. I mean, after all, we were kind of like the adherence police. You know, we showed up at their homes and drew their blood, and they probably really didn't want us coming back. So they probably were adhering a bit better after we left. But it was basically proof of concept that we could find out about these. Several of them took care of themselves, like half of them took care of themselves, which is great. But for the other half where we arrived while the interruption was still happening, this really served as a real-time intervention.
I have a question.
Yes, please.
On the prior slide. So, but you're saying that only 13 people had viral rebound. I'm just trying to understand what happened with the other 98%.
Yeah, so 18% of them had technical issues. It wasn't really an interruption. So you can take them out. Half of the rest of those, their interruption had already stopped by the time we got there, so we didn't investigate it any further. And there were about 15% where we couldn't either find them, or they didn't want their blood drawn, or we couldn't get a sample because of their veins, that sort of thing. Yeah. So this was published in JADES earlier this year, and you can see the full story. Yeah.
So the 587 is adherence interruptions for is wide field signal interruptions, right? Or is it really adherence interruptions? That includes all those people that may have had technical difficulties, right?
No, the 587, we're pretty sure this was real.
They are adherent.
Yeah.
So the fact that only 13 of them, it just may have been two days or even a week may have been too soon to see viral rebound, right? So
absolutely.
That's what we don't know yet.
Right,
Maybe
absolutely.
That's a little bit what we were getting at.
Yeah, so this is what we were able to do, and this was a Herculean effort to find these people. But what we found, it was reassuring, is this relationship here, even with all the limitations of not knowing, how long these lapses would have been or how many we missed, in those 50%, there were probably some longer ones, although most, I think, were shorter. This relationship is quite obvious, and this is the first in vivo, assessment of adherence and viral rebound. And kind of the take-home points of this is that every day does matter, but not for everyone. We've talked about some of the protective factors, and that this was a proof of concept for real-time intervention, but also that it looks like you've got about a 7-day window for most people, which is kind of reassuring, that the risk of losing viral suppression is around 5% or less for those short interruptions, especially if people have been taking medication for a long time before that. So that, if we're trying to think about rolling out real-time interventions, you do have a small window to work in. It's not every dose all the time. And that's what, going back to the history of adherence research, we thought, every single dose mattered. And, we don't tell our patients it's fine, just skip a week. That's not the message that we want to convey. But there is a certain degree of forgiveness, and you can factor that into thinking about interventions. Okay, and I do apologize. I'm going to go fairly quickly through several different studies, but please do stop for questions. I wanted to just give you an overview of the type of work I've been doing. So we're going to switch gears a little bit. This is a kind of a follow-up study, same settings as in rural Uganda. This was an R34 study that completed in June, and the paper should be sent off hopefully this week. But this is data that I presented at the Adherence conference in June. So this is a pilot RCT. And it was designed to really understand how could we do real-time intervention using these devices, the WISPO, and pairing it with SMS. So there have been a couple other studies recently published on this by Laura Sabin and Catherine Orrell, showing that it works, but we haven't been able to document the best way to do it. There have been some pure SMS studies that have shown that this kind of thing can be helpful, but not tied to behavior. So I wanted to explore different methods of doing this. And so that's where this design came from. So it was a 9-month study. In one arm, we had scheduled SMS. So these were SMS that went daily to individuals for the first month. And then they went, what are those beeps? Sorry. It's okay? Oh, is it me, like cutting?
No, it's not you. It's
okay. It's musical. And so after a month, it switched to weekly, because we were worried that people would get tired of getting daily SMS. And then in the latter 6 months of the study, SMS only went out if people didn't open up their devices. And so it was triggered by what could have been a lack of adherence. And then we also had another type of intervention where we sent SMS to social supporters who the individuals in the study nominated. Those people knew the HIV status of the participant. They had somehow helped them in the past, and we had definitions of what social support meant, so there's some standardization. And then if they would get these notifications in the latter 6 months of the study, if their participant hadn't opened their device for a couple of days. So trying to really enlist the social support that we know is very important for adherence, especially in resource-limited settings. Should I switch? Okay.
No, you can keep that one, just
I'm not going to get feedback? Okay. Two things.
You're used to this.
It's
right?
fine. No, it's fine. It's totally fine. And then in this arm, we skipped this scheduled SMS. Is this on too? And went straight into just sending out SMS for missed doses. And then in the latter 6 months of the study, these two arms essentially were the same intervention, but we did want to play around with them a little bit in the first 3 months. And then in the control arm, there were no SMS. So everybody was being monitored with a real-time device, which likely has some of an intervention effect on its own. But that was really the only way we could understand their adherence with consistent data. So we looked at general adherence, like percent adherence, and then less than 80, or greater than 80%, 48-hour gaps, and 96-hour gaps. And we did a ton of qualitative work, which I won't have time to go into, but I'll mention a few highlights. So what did we find? Using GEE regression analysis, basically we saw that overall adherence was pretty high in that first arm with the scheduled SMS. It was 92% by median, similar mean. In the triggered SMS, it was quite a bit lower, 84%, and a mean of 79. And the control was in the middle, but also, again, a low mean. And what we found was an overall intervention effect of 11 percentage points higher in the arm that had scheduled SMS, followed by the missed doses and the social supporter notifications, but really no difference between the one that went straight into the triggered SMS compared to the control. Looking at the lapses, we saw only about 4 over the 9 months of the study here, but 8 in the triggered arm and 4 in the control. The means were more similar in these two. And the intervention effect was again significant for that first arm, so the ones getting the scheduled SMS up front, but the triggered SMS and the control were similar. And then with the 96-hour lapses, so getting to the point where they're probably more significant, again, seeing strong effects in this arm, but no difference between the triggered and the control. Although I will mention that we're starting to see potentially some signal here that it's essentially identical at 48 hours, but for the longer lapses, it looks like it's starting to be protective, and the p-value is coming down, but this was a very small study and perhaps was limited by sample size. So if we look at this data over time, just to get a little bit more of a picture of what was happening, you can see the 9 months of follow-up on the x-axis and percent adherence on the y-axis. This blue arm is, sorry, I shouldn't have called it arm A. This is the scheduled SMS. The red dashed line here is the triggered SMS, and the green is the control. So this is visually showing you the same data that I just presented in the table. But what you can see over the first 3 months is that there is a general decline. And that's statistically significant in almost all arms. It's not quite with the triggered SMS. But if you look at the overall period, this is consistent within the scheduled SMS arm, but it continues to decline in the other 2 arms. So it's possible that there was some kind of a stabilizing effect of the SMS, either for the missed doses only in the first group or potentially through the social supporters. But this was an exploratory grant, so we don't have full data on what exactly was happening in a causal way. So what we learned from the study is that this was very feasible. It's only 63 people, but we had very complete data in the study and really didn't have any problems with the intervention. And we saw a very significant and I think potentially clinically meaningful increase in adherence in that first group with the scheduled SMS. And we did, like I said, a lot of qualitative work with Norma Ware, who's an anthropologist up at Harvard. And in brief, it seems like there's something about a habit setting, that's some sort of pattern that people are able to get through the daily SMS. And many of them were actually really sad when we stopped sending them. We thought we were going to annoy them, but they really liked it. And that may be a product of being in such a resource-limited setting where people are really stigmatized and marginalized from HIV. And then with the no clear effect from the triggered SMS, that was surprising to us. But people, again, through our qualitative work, suggested that that was kind of seen as being caught and kind of being like a negative consequence of not adhering. So I felt like they were getting their wrist slapped as opposed to just getting a reminder when they needed it. So I think the cultural interpretation of technology is really important. From a Western perspective, you don't want to be bothered. You're already getting 20 texts in a day. You don't want just another one, because the study said that you should have it. But people really liked them. So I think this, definitely will require more understanding. I think those are the main points I wanted to mention. Oh, and also one more thing. With the social supporters, we didn't see a clear benefit from that. And one of my colleagues in Uganda is currently analyzing that data in great detail. And we're just finding out how complicated these relationships are. And that's not surprising, right? Most people have complicated relationships in their lives, and people who have HIV are no different than anybody else. But when you try to activate that social support through technology, it can be really complicated. People have different expectations. There may be certain barriers. So we're diving into that data in depth right now, and it's very interesting. So maybe next time I come, I can tell you about that.
Excuse me?
Yes?
I'm sorry if I missed it, but what did the SMS say?
Oh,
Was the triggered SMS different from
yeah, so I didn't get into all the details of the design. The default was, this is your reminder in the local language of Runyankole, but people were able to customize. So if they wanted to say, like a lot of them had religious messages, like God loves you, or something like that. Some people used their name, so it could be really anything. But about half of people just stuck with, this is your reminder.
Okay, and the triggered was the same?
Yeah, it was the same. And the social supporters could customize their SMS as well. Mm-hmm. Any other questions before I go on to PrEP? Oops.
The daily or weekly reminders were at the time that people chose,
Mm-hmm.
or how did you?
Yeah, we let people, so daily they chose the time, and then for the weekly they chose the date and the time. Yeah. Yes.
Like, how did you recruit the 63 or 65?
Yeah, so we got people initiating ART, and then we asked them about their interest in the study. And the inclusion criteria, sorry I didn't go through all of the detail. We started off with 195 people to get the 63. And the most common reason that people did not get included in the study was because they didn't have their own phone with reliable reception and an ability to charge it. So we did definitely lose some people that way. We checked reception at the home to make sure that the devices could actually measure adherence. And a couple of people didn't want us going out to the home for stigma reasons. And there were a few people who had, who were not literate, or, a few issues like that. Yeah. Any other questions?
So then how did you measure adherence with this group? Did they just send a text message back saying they took the medication?
But they all had the WISE pill. Yeah. Anything else? Okay. Am I still doing okay on time?
Yeah.
Okay. Great. So we're going to switch hats and go to PrEP. Adherence for prevention. So the Partners PrEP study, I think most of you probably are familiar with this, but it was a very large 4,758 couple study in East Africa that was looking at efficacy of PrEP. So this finished in 2012. And within that study, people were randomized to either tenofovir alone, tenofovir plus emtricitabine or Truvada, or placebo, as a control. And so this is, very large scale, 9 sites, really huge effort to understand efficacy. And within that, we did an ancillary adherence study in about a quarter of the population. So we were working at 3 sites in Uganda. One was urban in Kampala, just outside of Kampala. And then 2 were more rural, one in Tororo and one in Mbarara, or Kabohe, which is near Mbarara, where I do a lot of my other work. So in this study, we used MEMS caps. And this doesn't sound like much, but this was a big deal. None of the other RCTs wanted to use MEMS caps. They said it was too hard. It was just, it was too much, which is crazy when you looked at all the CRFs and all the protocols that had to be followed. The study was involved in the FDA approval of PrEP. So all of the IND documentation, MEMS was a really small piece to add and very inexpensive compared to the overall trial. But just the fact that we were able to do this was notable. And really spoke highly of the principal investigators for that study, that they were willing to allow us to do this. So we found with the MEMS caps that adherence was incredibly high, which was great to see. And we used an intervention that got triggered anytime adherence dropped below 80%, so that we could target people who might need additional counseling. This was a CBT, motivational interviewing, kind of manualized intervention. I won't go into details about that, but it was very effective. And we found actually within our adherence study that PrEP was 100% effective. Nobody publishes 100%, but we actually did find 100%. The confidence interval using some fancy statistics was between 84 and 100. But all 14 seroconversions within this subset of the overall clinical trial were people on placebo. So what we were able to show using the MEMS technology is that if you kept adherence between 80% and 100%, PrEP works, which has been really important, I think, in the whole push to get PrEP out into communities. I will add this little caveat here that there were lots of gaps. So these lapses that we were talking about for treatment adherence, they happen for prevention adherence as well. Clearly, if, they were taking it well enough within this study. But I'll just plant this seed here and come back to it in a little bit, that about 23% of people had a gap of at least 1 week. And so we were wondering, is that important or not? It wasn't.
They stayed negative.
Yeah, they stayed negative. So within the context of the clinical trial, it didn't matter. Huh?
Do you know about sex?
Yeah. Yeah, so this was published in PLOS Med a couple of years ago. The biggest predictor of non-adherence was not having sex. Yeah, and people are smart, right? They're not at risk. They're not going to take it just because we told them to take it. And they were told often to take it. This was a clinical trial. This was not observational, real life. They were told, take it. Did you take it? And did you take it? Like over and over and over again. All right. So the key points from that experience were really that we could do this. And I get asked many, many times about randomized clinical trials or observational. I'm sure you guys have the same thing. I want to know about adherence, but I don't have any money and I can't use your fancy gadgets. So what's the best way to do this? I'm like, well, if you want to know something, you actually have to invest in it. And the cost of that sub-study was about 2% of the overall trial. So I think it can be done. It should be done. It doesn't have to be done in everybody, but in a small percentage of these big studies, I think it can be highly informative. Because if we had had this sort of data from some of those other trials where adherence was not so good, I think we could have learned about the issues much earlier and potentially either done something about it or limited the investment in those trials and shunted that money elsewhere. Careful adherence monitoring allowed for intervention delivery when it was needed, which I think is very useful for targeting interventions. And then, as I said, excellent adherence overall, but there were these kind of funny patterns that could potentially be a problem, and that sparked an area of research that I'll get into in just a moment. So I will say one more thing about adherence measurement within that study. This was a comparison. Again, people are asking what measures to use. So we did look at multiple ways of getting self-report, kind of rating your ability to adhere, how frequently did you take your medication, what % of doses were taken, as well as pill counts, and then electronic monitoring with the MEMS, either looking at 7 days or 28 days before a drug level. So we did drug levels. Blood was taken every month for HIV testing. Some of that blood was stored, and we could go back in a random sample and see what their tenofovir levels were. And basically, these are ROC curves. And so if the lines are completely up and down like this, that means they're essentially identical, and that we're not really getting anything useful out of self-report. This is kind of disappointing because we were hoping that asking these questions in different ways would get us a little bit more information, which has been seen in some settings, but not in this one. And with the electronic monitoring, we saw the best discrimination. So the line here is really like a coin flip. You want to be up here in this upper left corner. So we're not getting complete discrimination between detectable and undetectable tenofovir, but we're getting the best information with MEMS. Tenofovir itself is not the best adherence measurement either, especially when done in plasma, because somebody took their medication that morning. Potentially they took it within the last week, but the high levels are really seen with recent dosing. So we don't know about steady state, and it can easily be fooled by people taking a medication right before coming into clinic. And we have some more analyses looking at those differences that I won't get into today. But basically, we did see that electronic monitoring is probably the best measure of these options, and that tenofovir drug testing can be very useful, but because of that variability, it itself does not replace other adherence measures. So I think I covered most of that. I think there is potential to improve self-report through SMS, like what I was saying before. You can get more information more frequently. There's less recall bias. There's potential for reduced social desirability through the relative anonymity of a cell phone. And I'll talk about that in a minute. There are other pharmacokinetic measures that are being used in trials with dry blood spots and hair that get more at steady state adherence, and that may be more useful for looking at overall patterns, or overall adherence, but not the patterns specifically. Okay, so what are we doing now with from the Partners PrEP study? We've moved into a demonstration phase, so this is not quite implementation, but it's getting a lot closer to what does this look like in the community. So the study is about 2/3 of the way through. We enrolled just over 1,000 couples, so new couples, completely naive to PrEP, who are at high risk by definition. Their risk for HIV was estimated at least 5% incidence. Because of the serodiscordant nature of the relationship, the viral load of the partner who's positive, desire for children, we have a whole risk score that we use. And the short version of this story is that adherence is, again, very good. We are using MEMS caps in a demonstration context, and it's working fine, which itself, again, is a really important observation from this study. And that the data from MEMS and tenofovir, at least grossly, is very similar. And this is a paper that has just been submitted, but was presented at CROI earlier this year by my colleague Jared Baton, showing that in this demonstration context, so less rigorous follow-up than a clinical trial, but still good quality care, we've had an HIV incidence of less than 5% per year. The counterfactual is not a controlled study. This is just demonstration. But if we took that 5% year requirement, or risk per year requirement for entry into the study, and did a counterfactual simulation, we would have expected much higher incidence. And so there was an estimated reduction of 96% in this study. So really impressive, really encouraging that PrEP can be used in the community. And we can show with the MEMS data that adherence was really quite high. All right. So I'm going to go back just a little bit to those gaps that I mentioned that we saw within the clinical trial. And we're trying to figure out, are those important? So this led to a new area for me in research that we're calling prevention effective adherence. So is the adherence that people are demonstrating, is that going to be effective in preventing HIV? Because this is not like a like treatment where we know that you need to take treatment for life. PrEP needs to be taken when people are at risk. If they're not having sex and they're not taking it, fine. But if they are having sex, or they're having sex that is not protected in some other way by condoms, their partner being on ART, et cetera, then we do need to focus on adherence. And how can we refine that understanding? So this paper came out in AIDS. This was a group led by Kevin O'Reilly at the WHO. We met at the adherence meeting a year before last to talk through some of these issues, and this was the product of it. So what exactly is prevention effective adherence? So as I mentioned, when you're looking at ART in clinical trials, this is what you want, this arrow here. You want people to take it all the time. As long as they're on drug, they should be taking it, right? But when you're thinking about prevention, as I mentioned, you don't necessarily want this. In fact, you probably don't want that. PrEP is not for life. And this has been a real issue when we think about policy. And I've been involved in several discussions with ministers of health in East Africa looking at this data, and they're trying to decide, is PrEP something that we can afford? PrEP costs $78 a year in those settings, which is very cheap from a US perspective. It's a lot more here. But $78 per person per year on PrEP is actually a pretty significant amount of money. And it's about 1/3 of what treatment costs. So you can start to think about how these calculations are made. And if people go into this, they've heard from these studies that adherence is really, really important for PrEP. So people have to take it all the time. They have to take it forever. That's the message that people were getting. And so it's been a real barrier to rollout of PrEP, especially in resource-limited settings. So what we're trying to figure out is if somebody is having a potential HIV exposure, what is their adherence then? Can we find these periods of no risk? Can we guide people in coming off PrEP and then going back on it? Much in the same way that women deal with contraception. Obviously, HIV and babies are different, but they're both transmitted, products. They're products of sex, right? And so you can think about oral pills as a way to prevent either one. So high PrEP adherence in the absence of risk is not advantageous. That costs money. PrEP is very safe, but side effects do still occur. People may have anxiety about taking it. There are many reasons why we don't want people taking prevention if they don't, taking PrEP as prevention if they don't need it. And PrEP non-use is, in the absence of risk, is logical, but people may not know how to do it well. So can we use technology, real-time measurements of risk behavior, risk perception, and adherence to really understand how does this all align together? So what is the data that we're seeing in the demonstration project? So we decided to look at days in a week. So Pete Anderson's group in Colorado came up with some pharmacokinetic modeling to show you need 4 doses a week to be protected, at least within the MSM community. It's probably different for women. It's probably closer to 6. We don't know the exact relationship yet. But this concept of doses per week seems to resonate with people. It's not so abstract. It's not like a % of doses taken over a month. Most people can think of a week, say how many doses did I take that week, and is that good enough? So we looked at that in the demonstration project, and what we found was that we've got about half of people who are incredibly good at this. They take it every day, every week. Then we've got some people down here. This is still probably okay. Again, the message is daily adherence, but when you need it. But this is probably okay, and even this may be okay. But this 20%, 20 to 30% down here, those are people where we're wondering, are they non-adherent during a time when they really do need to be adherent? So let's think about how can we divide this up. And we'll start with a couple of assumptions. So let's say that sufficient adherence needs to be 5 doses a week. Now we could refine this a lot and look at gender-specific analyses. We could also look at things like condom use, partner ART use, other things to refine it. But let's just start with kind of a global view of this data. And let's call risk being sexually active with an HIV-infected partner. Again, we could quibble about this, but take it for now, that this is what we're calling sufficient adherence and risk. So what do we see with the data that's coming out of this demonstration project? So this nice large box here is what we would call prevention effective adherence. There's risk and there's sufficient adherence. So 74% of people are doing quite well. We also have a small box down here that's showing that there's no risk and insufficient adherence, but that's fine. So we've got 78% of people who are achieving prevention effective adherence. We have a few people over here who are the good doobies, right? They're taking their PrEP because someone told them to. They don't need to. And then we've got 16% here, which is, it's not 0, but if you're thinking about targeted intervention, 16% is pretty manageable. Okay, so I think I covered that. Am I still doing okay on time? Okay, let me know when I need to stop. Okay, so what are some other ways that we can try?
10, 15 minutes.
Okay, that should be good. So what are some other ways we could use technology to get at this idea of prevention effective adherence? Because this data that I showed you here, this was based on MEMS caps. So as much as I like electronic monitoring, I recognize that's probably not what most clinical care, that's not how most clinical care is going to be delivered, at least not any time in the near future. So what could we use cell phones to figure this out? So within the demonstration project, we're doing a sub-study looking at, this is a little bit old data that I presented last year, but we have about 300 people, actually 360 people within the demonstration project, so about a third of them. We're getting surveys from them for 2 weeks daily around times of clinic visits. So this is a 2-year study. We didn't want to send daily SMS for 2 years, even though people liked it in that other context. Probably would get annoying. So we decided to do it during, around the time of their clinic visits. We also are checking tenofovir levels at those clinic visits to see how things come together. So that design served several purposes. And then we give people a small incentive to encourage them to complete these surveys, which are about 8 questions. They ask about adherence, they ask about sexual behavior, things that would be helpful in figuring out if people are adhering when they need to. So again, this is very preliminary data, but looking at 187 people, lots and lots of surveys. At this point, that for the analysis, people had done about 2 of these 2-week periods on average. And we got about 3/4 of the data. As I mentioned earlier, missing data is an issue. You don't know why, what's going on when you're not getting the missing data, but pretty good for surveys. And we're seeing very high adherence. Actually, even it's a little bit better than what we saw with MEMS, which is not surprising. And just coincidentally, we don't know if this is causal, 78% of the days when we had non-adherence reported, people had reported not having sex. So kind of what we were expecting. So if you look specifically at the people who reported sex in the previous 24 hours, that happened in about 1/3 of the surveys, which is about what we were expecting. So just looking at that 1/3 of the overall SMS data, on days when people reported sex, 82% also reported PrEP use. Almost 70% reported condom use. 60% were the same, so that Venn diagram overlapped. These are the really anxious people who are, really protecting themselves, which is fine. It's good. It's what we asked them to do. And then there are about 9% of people who aren't doing either. But then we also looked if their partner was on ART. That was part of the design of the demonstration project, is to get the partner on ART while the HIV uninfected individual was taking PrEP, and eventually they could come off PrEP. And so if we looked at that, we're finding out that only about 6% of people are not protected. It's pretty good, right? We'd like it to be 0, but in a demonstration context, we're finding that only about 6% of people are potentially at risk. So really pretty encouraging. Okay, I think I covered most of this. Yeah, so the feasibility is important. A lot of people question whether SMS can be done, and I think we're getting really good data. Self-reported adherence is high. There is some evidence of suboptimal adherence, but again, when we look at other ways that people can protect themselves, they're generally doing quite well. All right, so any questions about that before I go on?
You chose to ask about sexual behavior in the last 24 hours.
Yeah.
And I know all the challenges about asking for longer periods.
Yeah.
But can you think about any way that you would implement to be more comprehensive, trying to find what happened before the 24 hours?
Like what time frame are you thinking about?
Well, like you're doing these surveys weekly, right?
They're daily for a week before and a week after a scheduled visit. So people may not always come in during that scheduled visit, but for that 2-week period around when they're supposed to come in, we're asking them these daily questions.
But if you wanted, just like you cover adherence daily or very frequently, if you wanted to find out whether they had sexual activity and it was with condoms or without condoms, and consistently, how would you do it?
Yeah, I think it's really, really hard because if you ask for longer periods of recall, like looking, I'm in a room with probably a lot of psychologists, so I don't want to go beyond my expertise here. But in the little bit of reading I've done in this and talking to lots of people who've done more, what I understand is the way the brain works, you remember discrete events for about maybe 3 days. The classic example is, what did you have for breakfast this morning? Right? You probably know what you had for breakfast today. Yesterday, probably do that, maybe even the day before that. But other than that, for longer periods of time, you're probably going to say what you usually do. If you always eat oatmeal, you'll say oatmeal, even though you have no idea if you actually had oatmeal 14 days ago, right? Whatever you have for breakfast. So if you go for longer periods, I'm afraid you're just going to get that gestalt, which may be fine for a lot of purposes, but when you're trying to align the risk and the adherence, I think you need probably more precision than you can get with those kind of estimates.
So that's a challenge.
Yeah.
How do you make it short? How do you make it short periods of the score, and so that the data is reliable?
Yeah. Well, I'm going to talk about a study that was a nice segue, this one. But it's a good point. Maybe you could do a week, potentially, but I think beyond that, you're really kind of fooling yourself that you're getting good data. Did you want to?
No, I think at this point, let's save for discussion.
Okay. All right. So I just have a few more slides. Is burning question?
Well, it was sort of a point. You made the parallel contraception, but I think everyone's accepted that you can't predict risk and time your contraception show well. The only way really to prevent unintended pregnancies is with long-acting reversible contraception like IUDs. We don't have to think about it, right?
Right.
And so I guess that's my concern, and maybe you're going to get to this, is sort of there's reporting your risk and the timing of your taking, but there's also predicting your risk. Like
Yeah.
a lot of the studies we do, the men go away for extended periods to go work, and
Right.
sometimes you can predict that timing, but that's, not everyone's life.
Absolutely. And so there's a whole parallel field right now looking at rings. So Jared, who I'm working with on a lot of this, is leading the Aspire trial, which is looking at vaginal rings for PrEP delivery. And even that, it's a once a month ring, that's complicated. Injectables are a couple studies getting started now. Those are incredibly complicated. I won't get into the details of that, but trying to understand how to study that, how to design those trials in an ethical way, knowing that daily PrEP is effective. If people have side effects, that sort of thing. And then what if they come in a week late or 2 weeks late? Then you have to retest them. Do you have to go through this huge procedure? So there are lots of complicating factors for any delivery method. But I think your points are very well taken. Women are not perfect in predicting. Obviously there are lots of unintended pregnancies, but there are a lot fewer than there would be if we didn't allow women, to choose. So I think that's where the parallel comes in, but you're absolutely right. Okay, so I'll just get through a couple more slides and then we can have more discussion. So I hopefully just got funded to do the study. We've been given the green light, but not actually the Notice of Grant Award. So this is a study called MPIA, which means new in Swahili. The W is silent. So it's monitoring PrEP for young adult women. So this is the group that really had trouble with PrEP. So looking at the FemPrep study, looking at the VOICE study, adherence was awful. And that's really complicated. That's a whole lecture in itself about why that was. And part of that's clinical trial design. Part of that is medical mistrust within a lot of these communities. But a lot of it was also the fact that we're dealing with very young women, usually under age 25, who are dealing with being young women. And being in settings where they don't have a lot of control over their lives, whether it's their sexual lives or just their lives in general. So how can we figure out how to make PrEP work for them? How can we use technology to understand that? And can we introduce this concept of prevention effective adherence so that women can make these choices while we're waiting for longer term methods that are real options? That's at a minimum 5 years away, I think, from where we are today, maybe 3, but it's a ways off, and there will always be a segment of the population that will want daily oral therapy. There are some people who just will never want the long-acting. So how can we figure this out? And can we do this in a population which really has very little options in terms of HIV prevention? Condom negotiation is usually not an option. They usually don't know their partner status, so ART is probably not going to be that helpful. So can we give them a self-directed choice that actually works for them? And so that's what this study is designed to do. It was in response to a special emphasis panel on looking at innovative measures for exactly this issue, for daily medication for treatment or prevention. This is obviously prevention. So we're hoping to measure PrEP adherence in just over 300 women using WisePill. These are going to be 18 to 24-year-olds, primarily in Kisumu and Thika, Kenya. Kisumu has a prevalence of about 28% for HIV. It's very high. And in Thika, it's a little bit lower. It's about 8%, but still pretty high. And looking at women who are at really high risk by definition. Sex workers, women who have survival sex, that sort of thing. And seeing if we can make this work for them. We're going to look at the WisePill device. There have been lots of studies. I'm sure we'll talk more about this later today. Lots of studies have had trouble with WisePill. And so there's a new version of it that is a bit more user-friendly. It's not quite plug and play, but it's getting there. And we're going to do a lot of kind of user acceptability testing and seeing what it would cost to use this technology in a clinical setting, so that if the price of the device were to come down to something that could be used in a clinical setting, what would really be entailed in doing so. And then the third aim is to look at this prevention effective adherence and using longitudinal surveys to understand behavior weekly, most likely is what we'll be doing. And really seeing if we can figure this out so that when we provide counseling to these women, we can do it in an informed way. How long should they take it? When should they take it? Will it be for the full 2 years of this study? What would they do if it were available in the pharmacy and they have to make that choice for themselves? So how can we tailor our counseling messages so that they can understand that? Because ideally this will be widely available and people will be making those choices. And then the final bit of work that I'll mention is a study that I just completed. It was an R20 on NIAID, looking at the ethics of what I do. which is always, it's deep self-reflection. Is what I'm doing the right thing to be doing? Are there unintended consequences of using technology? Do people like being monitored? Does it interfere with their relationships with their providers? Is there an issue of mistrust? And so what we did in the study, we started off developing normative frameworks. So I'm not an ethicist. I partnered with Nir Ayal, who's an ethicist at Harvard Med School. And we spent a year doing like philosophical research on this, which as an internist was, felt like back in college, like learning about philosophy and ethics and that sort of thing, which was great. And really applying it to electronic monitoring. And then we spent the second year of the award collecting data from our participants in these various studies that I've mentioned in East Africa and understanding what their experiences were like. And then also looking at people who didn't want to use our gadgets and why didn't they want to use them. Talking to providers, we did a focus group with some community members about how these things are perceived. And then we're in the process right now of preparing ethical recommendations based on our findings. Just to give you a little bit of information about what we've learned so far, is that most people really like them. I think when I present this data to a lot of Western audiences, people are worried about being monitored. They see it as Big Brother. It's this big invasion of their autonomy and their privacy and so forth. But the short answer to a lot of research that we've been doing with this project is that people really see it as a sign of caring and a sign of support. People love the fact that we're taking the time and spending the money to make sure they're doing well. So I think this kind of technology can be done really well. But in some preparatory focus groups I did 2 weeks ago in Nairobi, the young women for that PrEP study that I talked about, they were a little bit anxious about it. Getting a text message from who knows who, maybe a boyfriend sees it and they may have another boyfriend, who's paying their rent and this one's paying, for other things. That could be problematic. So I think it's really important to pay attention to these issues and understand how technology can be used really positively and how we can have negative consequences, which we're also exploring in that study where we had the social supporters and understanding why some social supporters did well with it and others not so well. Oops. So just to sum up all this potpourri of projects, so I think electronic adherence monitoring is really important for revealing patterns of adherence. It's really the only way to understand behavior. You can do lots of different things to measure adherence, but if you want that day-to-day behavior, you really have to be looking at it day-to-day. And the real-time monitors allow for real-time intervention, which is potentially very promising, although not always. It depends on how you do it. And that SMS can improve adherence and enable this concurrent behavioral assessment, like I was describing for prevention effective adherence. And then as I was raising with the ethics project, we've learned that technology can be a very powerful and positive intervention for adherence. And this is a quote from one of our participants, which I think really sums up that point I was trying to make earlier. So this is a HIV positive woman from the R34, that small pilot RCT. And she said, I was still at my business working and I received an SMS. I read it and became happy and told myself, these people remember me, they care about me. She didn't emphasize the fact this was an automated computer sitting in Cambridge, but that's how she experienced it, And that's really important. So there's a lot of potential. It's a lot of really, I think, warranted excitement in this area, but I think we have to be very careful about how we do it. Measure it as we go, look at the technical limitations, look at the social and individual limitations through qualitative work. But I think there really is a great deal of potential here. So I think in the future, we should be looking at technology for interventions that are powered by viral loads so that we can tease out SMS versus the monitoring itself, which definitely does have an impact on adherence. Looking at lower cost production, this is some work that's going on in parallel so that we can hopefully do this at large scale. And then again, as I said earlier, adding these objective measures to large studies I think is feasible and really should be done more often. Oops. So I'll finish thanking the NIH for funding a lot of this work. These are my primary colleagues, the technology groups I work with. Norma and Monique do a lot of our qualitative work. These are some of the many people who support us in Uganda, our many study participants, and oops, very small print here, but the Partners PrEP study was an enormous effort. These are many people who made that possible, and the demonstration project is still very large, but a bit smaller than the clinical trial. So I'll finish there. Thank you.